Okay, it is April the 1st, 2024. It's April Fool's Day. In fact, I knew a gentleman one time, worked with him. It was his April the 1st was his birthday, but I'll name no names. Andrew probably knows who I'm talking about. Anyway, today we're going to talk about not pathophysiology, I'm sorry. We're going to talk about diabetic emergencies and altered mental status. We're going to talk about pathophysiology as related to that. April Fool's on me, I guess. We're going to hopefully get into allergic reactions today. What we do not cover, we will go ahead and cover on Thursday when we meet in person at the park. Okay, so let's talk about altered mental status. Altered mental status is a term used to describe a broad spectrum of abnormal responsiveness, clarity of thought, or mood that ranges from slight anxiety to unconsciousness. So, altered mental status could actually be an emergency into itself. And we are going to talk about altered mental status, several different things or several different ways that altered mental status can present itself and what we can do to help treat those patients. Sometimes altered mental status is the first sign of an emergency situation. Let's see. All right. Pathophysiology of altered mental status. Before we talk about altered, though, we probably want to talk about what's normal. Awake and oriented times 3. The person generally knows who they are, where they are, what the date is, and really what's going on as well. That's normal for most adults and most children as well. Some folks are normally altered from different disease processes such as dementia. The book has a term that we need to know called reticular activating system, or RAS. The reticular activating system is a series of neurologic circuits in the brain that control the functions of staying awake, paying attention, and sleeping. Seems like a lot of people have trouble trying to stay awake. I'm one of those. And that may just be from exhaustion and fatigue. But a lot of people out there have trouble paying attention. And that could be a medical or psychological issue. Or again, that could be based on fatigue or some other condition that we're going to talk about. Some people want to sleep all the time, or others can't sleep at all. When we assess patients with altered mental status, probably the most important thing you can remember as an EMT is to be safe. Many times these altered mental status patients are really unaware of what's going on around them. Just like an animal that's scared or confused or disoriented, these altered mental status patients may not know how to act and socialize appropriately. They may become dangerous to you. They may see you as a threat. They may see their situation as a threat, and they may not know what to do other than the fight in order to survive. So always be sure to maintain your personal safety. Make sure you've got adequate help, and if necessary, you may need to contact law enforcement. Some altered mental status situations occur in facilities such as nursing homes, and law enforcement may be less needed in those situations versus scene calls, which can be really uncontrolled and unpredictable. You really don't know what someone's going to do if they're not thinking straight. And then if you invade their personal space, their home, it may aggravate the problem a little bit more. So you may need law enforcement to help you. Always when doing or treating a primary or an altered mental status patient, we're going to begin like all other calls. We're going to consider what dispatch information that we receive, and we're going to use it to help plan our activities. We can think and make mental notes that, hey, I need to look for this kind of stuff, or I need to look for that kind of things going on at the scene or with the patient themselves. Also, when you get there, we need to use our appropriate personal protective equipment, ensure our scene is safe again, enter the scene, and locate your patient. When we approach your patient, we get a general impression of our patient. We just look at them. What does the patient look like? Does the patient appear to be in distress? Do they appear to be confused? Are they acting strangely? Is your patient surrounded by medications or some sort of possible illegal substance? Is there a strange odor in the air? Do you see a glucometer on the table? And Andrew will tell you what a glucometer is, I'm sure, and why that would be significant with their altered mental status patients.
Yeah, so a glucometer is a device that measures blood sugar level. Anyone that has a diabetic in the family has probably seen them poke their finger and put a little bit of blood on a test strip that's plugged into a machine, and it gives them their glucose reading. And oftentimes, diabetics, especially really bad diabetics, have multiple, and they always, in my experience, keep one within arm's reach of themselves. So if they're sitting in a recliner in the living room, there's probably one on the table next to them, and so that would give you a really good impression that, hey, maybe this is a diabetic emergency, and that's what's causing the altered mental status.
That definitely helps you with your assessment of your patient. So we've done our initial assessment of our patient. We've initially assessed their scene before we do anything else. We look for things such as difficulty breathing as well. We get into our airway, breathing, circulation issues. If we see an airway problem, we find a breathing problem, if we find a circulation problem, then we're going to stop and we're going to attempt to treat those. And we're going to manage those life threats first. As we continue with our assessment, our initial or primary assessment of our altered mental status patient, we need to assess the level of consciousness. And the little mnemonic that we use for assessing mental status and level of consciousness is AVPU. AVPU. Alert stands for, or A stands for alert, and alert means the patient is aware of what's going on and kind of understands. V stands for verbal. If the patient scores a V, that means you may have to speak to the patient in order to wake them up and to get their attention. It might be kind of like somebody that's asleep back in the back of a classroom and the teacher's got to yell their name. I had that happen occasionally when I was in school. Then we've got painful, or P. And with P, we're doing some sort of physical stimulus in order to get that patient to respond to us. Now, it doesn't always have to be pain. Maybe just a gentle touch on the shoulder, shake their shoulders. Maybe you need to pinch their finger in order to elicit a pain response. You can increase the amount of force that you use slightly as you go along to see just how much it takes. Now, if the patient doesn't respond to anything at all, you are unresponsive. Okay? Any patient that is unresponsive, you've probably got an emergency. Very, very likely that you have an emergency. Any patient that responds only to pain, it's very likely that you've got some sort of emergency. Verbal, well, maybe, maybe not. Is this, if the person is becomes alert and oriented or aware after they've been spoken to, they may have simply been asleep. Okay. Other things we want to be aware of. Does there appear to be any type of trauma? Does this appear to be a trauma call instead of a medical call? Things that might clue you in that you have a trauma call. Is the patient is found lying somewhere or just in an unusual place? Has the patient fallen from a ladder, fallen from a chair? Have they been physically assaulted? Do you see injuries? Do you see blood? If you're in doubt, go ahead and assume that this could be trauma related and control C-spine if you're able to do that. Okay. One of your more common causes of altered mental status is diabetes. Diabetes is simply a disease in which the body does not utilize sugar appropriately, and that sugar is known as glucose. Glucose is the body's fuel source. Without glucose, your body has got to find some alternative fuel source, and it's not very efficient. Okay? Generally, diabetics either don't produce enough insulin or they don't produce any insulin at all, or maybe they have a body that has become resistant to the insulin that is produced. So there are medications out there that help with those issues. Insulin is produced in the pancreas. It's a digestive hormone. Insulin can also be taken in the form of an injection by a diabetic. Without insulin, glucose cannot enter the cell and cannot be utilized. So, if we have a lot of sugar in the bloodstream, but not enough insulin, that sugar or glucose is virtually unusable without an adequate amount of insulin being present. If we run totally out of sugar or run out of glucose, you're going to see about the same type of mental status with your patients. Okay, two types of diabetic emergencies: hypoglycemia and hyperglycemia. Hypoglycemia means low blood sugar. Several things can cause hypoglycemia. One of the things is maybe the patient took too much insulin or too much oral medication, because there are oral medications out there to help treat diabetes as well. And that glucose is transferred from the blood into the cells very rapidly, and then the glucose becomes depleted. Okay. Another potential cause of hypoglycemia is reduced sugar intake from not eating. Maybe someone who's a diabetic decides that they're going to try to lower their blood sugar by cutting their sugar intake, and that's okay until the sugar intake becomes way too low to sustain what the body needs to function. Okay, maybe someone has overexerted themselves or overexercised, and they use up the sugar stores fairly quickly. Or what happens if you have a patient with nausea, vomiting, and diarrhea? Well, these GI issues with the nausea, maybe the patient didn't want to eat. With the vomiting, maybe the patient ate, but then threw the food back up so that they were unable to absorb the glucose in the meal. Okay. Sometimes the metabolic rate will increase from shivering or with fever, and that will cause a depletion of the blood sugar. The body is not very tolerant to low blood sugar at all. When the sugar becomes too low, the patient starts to go into what we call insulin shock or hypoglycemia. With hypoglycemia, and of course going back to the word shock, the patient starts to exhibit some shock symptoms. Shock symptoms include confusion or altered mental status. Patient may present with cool, clammy skin. Those are signs of hypoglycemia. Now, hyperglycemia is a different animal in itself. Hyperglycemia occurs when there's too much sugar in the blood, but you can't utilize that sugar. One of the primary causes of hyperglycemia is overeating. Another is lack of exercise. And the third is inadequate insulin production or inadequate insulin supply. Hypoglycemia occurs very rapidly. That's low blood sugar, but hyperglycemia develops over time. It may take several days for hyperglycemic emergencies to appear. Now, if we all remember back just say 5 or 10 minutes ago, I talked about glucose being the fuel for the body. When the body does not have the correct fuel supply, doesn't have glucose entering the cells to power the body will start to develop an alternative fuel supply. And that alternative fuel supply is fat. So what's so bad about burning fat as fuel? In itself, nothing. However, when fat becomes the primary fuel, we start to develop byproducts called ketones. Ketones are a byproduct of fat metabolism, fat burning. So when we metabolize fat, we develop ketones. A few ketones are not an issue. However, the buildup of ketones within the blood causes the person to develop a condition called diabetic ketone acidosis, or DKA. Along with the buildup of ketones, you will find the patient may become dehydrated because the kidneys are trying to clear the ketones out of the system. Mental status will be altered because the ketones are essentially a poison to the body. And you may see an altered breath. Sometimes these diabetics have a really sweet or fruity smelling breath. However, your initial assessment of your patients, or your primary assessment, you're going to find altered mental status. Okay, so if we have a patient who is a diabetic, we're going to, of course, with all patients, we're going to perform a good and in-depth sample assessment or sample history. If we go over sample, remember S is for signs and symptoms. Generally, in this situation, our primary sign and symptom is altered mental status. We're going to ask about allergies. We always want to know about the patient's allergies. we're going to ask the patient about medications that they take. And if the patient can't tell you, hopefully a bystander or family member will. Medications to be particularly aware of are, number one, insulin. Well, we know if a person takes insulin injections, that person's probably a diabetic. Okay? Maybe the patient takes some of these newer injectable medications, such as Trulicity, Mounjaro, Victoza. There's several of those things out there now. Maybe the patient takes some oral medications, such as glucophage or metformin. All those should kind of clue you in that the patient is a diabetic. Okay?
Well,
Then we
and
go,
if I can add in, sometimes
go ahead.
you'll see like the glucophage or the metformin or even an injectable medication like Ozempic prescribed to the patient for weight loss. And I have seen a few patients over the last few months that have developed hypoglycemia or low blood sugar because they're taking these medications, and even though they're not diabetic, it's still causing too much of a decrease in their blood sugar. And so they're taking it for one thing and it causes an entirely different issue. So just be mindful of that.
Yeah, that's a good point, Andrew. I've ran into multiple people that are now taking these medications for weight loss. Basically, they work as an appetite suppressant. I was taking Mounjaro at one point, and I probably went from eating 6,000 calories a day to 1,500. And I was having to decrease my insulin intake because I'm a type 2 diabetic or adult onset diabetic. That's why we're going to get into P of our sample history. And that's past medical history. Point blank, are you a diabetic? Do you have a history of diabetes? But you know, it may not just be diabetes with these altered mental status patients. The patient possibly has a history of seizures, possibly has dementia, possibly has some sort of mental illness related issue, organic brain syndrome, history of head trauma. That's all important to know as we continue to assess our patient and formulate our treatment plan. L stands for last oral intake. How many folks routinely ask their patients, what did you eat last? When was that? That's very important, especially with altered mental status patients when you get into diabetics, because lack of eating can be a causative factor. Okay? And then E, events leading up to the injury or illness. What were you doing when all this stuff started? Was the patient running a marathon? Was the patient sitting and watching television? Give you a couple diabetic stories from days gone by. I had an uncle, hardworking guy, worked in coal mines, packed a big lunch bucket full of all kinds of goodies to take to work with him. I'm talking Little Debbie cakes, Mountain Dew, the works. There's probably a sandwich in there, but I think between a dozen Little Debbie cakes and a couple Mountain Dews, he was set for the day. Well, he had finally worked long enough and hard enough that he decided it was time to take a vacation. So my aunt and my uncle left on vacation. They go to the Smoky Mountains, rent a cabin. They're enjoying themselves when my uncle gets very sick. He's nauseated. He just feels terrible. Has no energy. He goes home. They cut their vacation short. My aunt goes back to work. My uncle goes to see the doctor. And the doctor says, did you know you're a diabetic? My uncle's blood sugar was extremely high. So what changed in his world? He was still eating. He Didn't take any diabetic type medications because there was no need for them at that time. But he was taking it easy. He was no longer getting the exercise or physical activity that he was used to. That's why his blood sugar went up. So my uncle ended up in the hospital. They got his blood sugar down, got some medications, and for a long time he was actually able to regulate his blood sugar with diet and exercise. As he got older, they had to start adding medications back. Okay. How do we determine if a patient's hypoglycemic? On Thursday, we're going to get out the device called a glucometer. And just like it sounds, this is a meter that tests blood sugar or glucose levels. If you are associated with an EMS agency, which I guarantee most of us are, your EMS agency has a protocol in place to allow you to check blood sugars. Here's the kicker. Glucometers come in several different forms, and you need to become familiar with what machine your agency actually uses, because they look different. They use different types of test strips. Now, some patients you'll find come with their own built-in glucometers now. This is a device which attaches to the patient. They usually wear it anywhere from 7 to 14 days. It's an electronic monitor, and this monitor is paired either to the patient's telephone, their cell phone, or through a special reader device, which allows them to keep a constant check on their blood glucose. I worked with a gentleman he was called a Dexatron, I believe. And the Dexatron would send a message to his cell phone. The cell phone would alert and say, hey, your blood sugar is too high or your blood sugar is too low. Those are really neat.
So I've got somebody that my partner at work at Life Care, and they have me set up on their Dexcom to get notifications if their blood sugar drops. And the device is just like a little round, maybe quarter size device. Maybe some of them are oblong, usually on the upper arms or maybe on the lower abdomen is where you'll find them. But I was going to see if I could try to hold this up to the camera, but I don't think it's going to work. But the app will show you what the current reading is. It has a chart showing you what the readings have been over the last 24 hours. And it's a phenomenal thing to have, because you can see on an altered mental status if they have one of these, how have their blood sugar been fluctuating? Has it gone really high and then dropped really low, and gives you a little bit more insight.
Yeah, I really like that setup. I think it was neat that we could see that her blood sugar was 85 currently. That's about the only thing
I'm
I
messaging
get.
her because I was hoping it would show up good, but I'm texting her now telling her to eat something.
Yeah. 85 is probably a good blood sugar for a healthy person, but for a diabetic, that's starting to work its way down. I know personally, I feel best when my blood sugar is about 250. Hopefully, I'm slowly fixing my problem. Okay. Let's talk about the treatment for low blood sugar, for hypoglycemia. We really have two different treatments that we can administer as EMTs. The first one, I want you to read up on oral glucose. That's a sugar-based gel that's squeezed in between the patient's cheek and gum, and it will help increase the blood glucose levels because that glucose is absorbed through the mucous membranes of the mouth. The major contraindications for oral glucose are unconsciousness and inability to swallow. So if the patient is unconscious, if they're unable to swallow, that means they're unable to maintain their own airway. And as EMTs, we never want to give anything by mouth to someone who cannot maintain their own airway. We simply don't, we're trying to avoid choking. We don't want the patient to choke on, we don't want the patient to aspirate or breathe in the medication. And if in that case, we're creating bigger problems. Okay. We are going on Thursday to actually handle some oral glucose and demonstrate it. And I'll demonstrate its use, and we'll do that in a practical session so everybody in class gets to simulate the administration of oral glucose. Good stuff. Always remember, though, your big contraindication is altered mental status, unable to maintain their own airway, unable to swallow. So I'm going to switch us over and I'm going to try, let's see, I'm going to try to share a video about glucagon. And I don't know if Andrew can see this or not.
Yeah, I can.
Line.
It's showing up.
BLS glucagon administration. In this training, we're going to review the drug reference for glucagon available in the 2018 ODEMSA patient care protocols. Including in that, we're going to discuss the indications for glucagon administration, as well as we're going to go over the steps for preparing glucagon for injection. Glucagon is a naturally occurring pancreatic hormone. It is released by the pancreas to increase blood glucose levels. Glucagon works by stimulating the release of stored glucose in the liver. The indications for BLS providers are to give for suspected or confirmed cases of hypoglycemia. Oral glucose is the first-line treatment for hypoglycemia. However, glucagon can be administered if oral glucose administration is contraindicated in cases where the patient is unresponsive or unable to control their airway. The major contraindication for glucagon is known hypersensitivity to the medication. Use caution in patients with cardiac disease or coronary artery disease, as glucagon can have a sympathetic stimulation effect on the heart. Also, geriatrics, patients that have malnutrition, alcoholics, hepatic disease, or renal insufficiency. The pregnancy is pregnancy class B. The dose for glucagon for BLS administration is 1 milligram IM. 1 milligram is going to be the full vial. Remember that BLS providers are not able to do med math, so they'll have to administer the entire vial. For pediatric patients that weigh 20 kilograms, which is 44 pounds, BLS providers can administer 1 milligram IM. Again, that is the full vial. There are other indications for glucagon. However, BLS providers should only administer glucagon for suspected or confirmed hypoglycemia. The onset is about 30 minutes for glucagon. If you've run with ALS providers and you've had hypoglycemic patients, you may have seen them give intravenous glucose, and the patient wakes up pretty immediate. However, once you give glucagon, it may take several minutes for you to see any response to the medication, and that's completely normal with glucagon since it has an onset of 30 minutes. The duration is 1 to 2 hours. There are side effects, nausea, vomiting, and other rare side effects, angina, urticaria, and dizziness. It can interact with beta blockers, so be sure to monitor your patient's vital signs and blood pressure if the patient is taking those medications. Some things to consider when administering glucagon. Glucagon only works when there are normal liver stores of glycogen. It will not work in patients with chronic hypoglycemia, malnutrition, or starvation. It also may not work in patients with chronic alcoholism for similar reasons, including hepatic disease. First-line treatment for hypoglycemia is always glucose. Use glucagon as a last resort in insulin-dependent diabetics, as they will already have depleted stores of glycogen. Glucagon will deplete glycogen stores further, and it takes some time for the stores to regenerate. Any patient receiving glucagon should be transported to an appropriate medical facility to be monitored for refractory hypoglycemia. Preparing glucagon for administration. First step is to prepare your equipment. Have the glucagon package, alcohol prep pad, and we recommend a 3 ml syringe. A 1 ml syringe will also work, and we recommend a 21 gauge needle, which is usually the green hub, is what we recommend. Open the package and pop off the tops for both vials. Open the syringe. If need be, screw on the needle. Insert the needle into the vial of sterile water and carefully draw up the entire volume, which is 1 milliliter. You should invert the vial, and you may need to retract the needle slightly to ensure that all the fluid is drawn up. Next, insert the needle into the glucagon vial with the powder. Slowly inject the fluid into the vial. Now keep the needle in the vial and mix the powder with the water. Do not shake vigorously, but you want to swirl the contents until they're mixed. Just know that shaking or vigorously mixing can cause bubbles to form, which will make it hard to draw up the medication. Next, invert the vial and withdraw the needle slightly so that all the contents can be withdrawn. Draw up all the contents from the vial, which is approximately 1 milliliter. Removing the needle from the vial, it's helpful to draw a small bit of air. Knock out any air in the fluid and inject the air until the fluid starts coming out of the tip of the needle. Agencies should provide additional hands-on training in mixing and giving IM injections before you would be allowed to give glucagon injections. BLS providers are not authorized to administer glucagon unless specifically authorized by their OMD. Any questions, please contact the ODEMSA Training Director, Megan Young, at the number or email on the screen.
Okay. Stop sharing that. I guess I'm back. Give you a little.
Albert, do I have the ability to share something on the screen?
I believe you probably do. Do you see the share up top?
Yeah, I got it. Let me share this too, because I didn't know that this was anything that had even come into existence or was getting prevalent. But can you see the auto injector?
I can.
So now they are prescribing auto injectors for glucagon, and these are two of the ones that I've seen over the last few months with diabetic patients. And so I don't know if they will make their way onto an ambulance, or if it'll become, become kind of like the EpiPen, to where, you have a hypoglycemic patient that you'll be able to assist them with their glucagon auto injector. But I just want to make everyone aware that, that this is something that's now available and is starting to become pretty prevalent with diabetic patients, but especially the ones that have bad drops in their blood sugar.
I'm going to suspect that those auto injectors, the glucagon auto injectors, will probably be so expensive they will never make their way into their drug box. However, the patient may actually have them in their possession. The last point in the video, though, BLS providers are not automatically authorized to administer glucagon. That is something that requires medical director approval, requires protocols, and requires additional training. I just wanted you to kind of see what's there. A lot of your rescue squads or 911 response agencies are actually allowing this now, or their medical directors are allowing glucagon administration. Some of your ambulance services still are not. And that a lot of that probably has to do more with provider training and availability of the resources. Most of your basic life support ambulances operated by private services are not equipped, or at least not fully equipped with all of the medications that their ALS ambulances are equipped with. Glucagon is generally stored in the advanced life support drug box. I think things are getting better, but sometimes when you get into private services, the wheel turns just a little bit slower. I've worked for a private service for many, many years. Andrew works for one now, and it is different. It really is different with how those agencies operate. Glucagon, with its long onset or delayed onset, well, that delayed onset will reduce its effectiveness in the field, just so you know. Your advanced life support providers are going to attempt to start an IV and give glucose via the IV route, and you see an almost immediate reaction with that. Now, if we go back, turn the page back another couple of steps, the oral glucose that ambulances carry, you will see an almost immediate reaction or improvement in the patient's condition. Currently, our protocol over here in Clintwood, and I believe most of Dr. Phillips's agencies are following the Southwest Virginia protocol, we're not administering any type of medication, whether it be oral glucose or glucagon, until we've confirmed that the blood sugar is under 60. And you do that using a glucometer. In years past, we were taught if we were in doubt, we had a suspected hypoglycemic patient, we did not have a glucometer, but all the signs and symptoms and history were there, that we could go ahead and administer oral glucose. Theory being, there was not enough glucose within the oral glucose dose to hurt someone whose blood sugar was already up there, but there was enough to positively improve the patient's condition if their blood sugar was low. But, our EMT classes always try to go by general guidelines and what you're going to be tested on, the national standards. Some places here in Virginia have very advanced protocols, and it's nice, but you got to receive additional training on that. The video that we just watched is in the email. It's a link from the email that I sent out last night. there's an additional video or two in the list, including stroke assessment and nasal Narcan administration that we're going to talk about here in just a second. If you go on YouTube, you can actually find some additional glucagon videos. The big idea behind glucagon is it causes the body to release stored sugar or stored glycogen from the liver. If you have a patient who gets a glucagon injection every day, you're probably not going to have a big improvement from the glucagon because you've already depleted those stores in the past. If you have someone who is, say, in jail on a hunger strike, or someone who's extremely sick and is not eating, those glucagon or those glycogen stores have probably already been utilized. And if you have someone who is an alcoholic or has some other sort of liver condition, you may not see as much of an effect out of the glucagon either. Something to think about. Okay. Let's talk about some other causes of altered mental status. One of those being seizures. Now, over here in Clintwood, we used to have these brothers who had law enforcement induced seizures. Every time that the guys would go walking down the street and they'd see a police officer, these two brothers would fall over on the sidewalk and have a seizure. That was the get me out of jail seizure. But seizures are actually a real thing. They're not always funny, and they're not good to joke about. Seizures happen when the electrical activity from within the brain becomes disorganized. The brain produces and the nervous system distributes electrical activity in a normal pattern, in a known pattern that can actually be seen on a device called an EEG. Okay. And when those electrical signals become jumbled, that can result in a seizure. A couple different types of seizures. There's a partial seizure, which may affect only one part of the brain, a generalized seizure, which can affect both sides of the brain. Then we've got something called a tonic-clonic seizure. These tonic-clonic seizures can begin by, they appear that the body just stiffens up. That's the tonic phase. And then the clonic phase is when you get the jerking, the stereotypical seizure that we all think about. The patient flops around like a fish out of water without rhyme or reason. Then their patients have a post-ictal state, and that is the period of confusion and fatigue that follows a seizure. If you could imagine expending enough energy to run a marathon within just a few minutes, when you have someone that's having a grand mal seizure where they're flopping and jerking and just really unaware of what's going on, it's possible to expend that amount of energy. That's why they're tired. And then with the electrical activity of the brain kind of out of whack, out of kilter, the patient will be confused. There's a term called aura, A-U-R-A, and that's a sensation or feeling that a seizure patient may have. It precedes a seizure. It's almost like a warning sign. And some people are very in tune with auras, and they realize that, hey, I'm getting ready to have a seizure, and they will sit down or they will lie down or they will spit their food out so that they're getting ready for it. And that's a good thing. Okay. Several different causes of seizures out there. The first at the book list is hypoxia, and hypoxia is simply low oxygen. Well, if the brain doesn't get enough oxygen to function correctly, a seizure can result. Strokes can result in seizures, and we'll talk more about strokes as we go on, but a stroke is either caused by a blood clot or a bleed within the brain. It affects the brain tissue itself. Traumatic brain injury can result in a seizure. And now that could be an acute or sudden new onset traumatic brain injury. Maybe somebody's been struck in the head by a tree or a hammer and they have a seizure. Or this can be a chronic issue. Maybe the patient had a traumatic brain injury 25 years ago, but the resulting damage can result in occasional seizures. Toxins, drugs, alcohol, environmental toxins, all those can result in seizures. Hypoglycemia or low blood sugar can cause seizures. Brain tumors. Sometimes you'll have an elderly patient who ends up having a seizure, and it doesn't have to be elderly, but let's just say someone you don't expect to have a seizure develops a seizure. There's a brain scan, some sort of CT, and it's determined that the patient has a brain tumor that no one knew about. That could be a cause of a seizure. Congenital brain defects. Maybe the brain just was malformed at birth, didn't develop correctly. That can result in seizures. Infections can cause seizures, especially the swelling and inflammation of the brain tissue itself. You could have some metabolic issues. Maybe the body chemistry is off. That can result in a seizure. There's a condition called idiopathic seizures. And idiopathic means that a condition occurs spontaneously and we don't really know why, from an unknown cause. Other things that you might see seizures with: measles, mumps, and other childhood diseases, heat stroke. And heat stroke is exposure to high temperatures. We all know if our computer gets overheated, it'll shut down. Well, your brain is your body's computer. If it gets overheated, it will malfunction. Sometimes people will seize upon fainting or syncope. Probably the most common cause of seizures that I see is epilepsy. And epilepsy is simply a medical condition. It's a disease of seizures. Epileptic patients are known to have seizures. We really don't always know the exact cause of the epilepsy. And a lot of these patients receive medications to help combat seizures. So that goes back to your sample history again. What medications do you take? If you hear medications such as Keppra, that is a anti-seizure medication. What else might you hear? Divox, Depakote. Depakote is also called valproic acid. And the patient may have a prescription for generic valproic acid versus Depakote. Some patients actually take some benzodiazepines to help with seizure disorders. A lot of times, your people having a seizure become incontinent. That means they will use the bathroom on themselves. They will drool. They may fall and have those uncontrollable jerking motions. Patient may hit their head on the floor, either from falling or from the movement of the seizures. In fact, the last seizure that I saw, the lady Said, I think I'm going to have a seizure. She falls down, and it was a legitimate seizure. She became incontinent, and she began to strike her head against the asphalt. So how do we treat seizures? The first step in treating a seizure is to make sure the patient remains safe and that you remain safe too. We're going to assist the patient to the ground. We're going to ensure that they don't strike their head or other body parts on objects or the ground. You may want to put a pillow under the patient's head, or a coat or blanket, whatever's handy. We're not going to restrain the patient though, because you could actually create some injuries in that process. Once the seizure ends, or the patient becomes manageable enough, we're going to roll the patient up on their left side. And the reason we're going to roll the patient up on their left side is to allow the airway secretions to drain out of the mouth. So, but why do we prefer left side versus right side? The left side versus right side has to do with anatomy. The aorta runs the length of the body. I'm going to adjust my camera a little bit. Kind of on the right side. It's the big artery that feeds the lower part of the body. Well, if you lay a patient on their left side, the weight of their abdominal organs shifts to the left, and then the aorta is not compressed. If you got somebody with one of these big round bellies like I've got, you can improve circulation by laying them on their left side or laying them on their left side. Also, with pregnant ladies, you can do this. It has the same effect. Okay. So we're going to help the patient to the ground. We're going to loosen any restrictive clothing, remove objects that may harm the patient, protect them from injury. After it's ended, we're going to assess our patient. Airway, breathing, circulation. We may have to open the airway. We may have to administer rescue breaths, at least temporarily. We may have to administer oxygen in order to help stabilize the person and bring their oxygen back up into a normal range. Hypoxia is kind of common after prolonged seizures, especially. Treat them for any trauma that may have developed as a result of the seizure. And we are going to transport the patient to a medical facility, and we're going to monitor them appropriately. Now, never put any type of object in the seizure patient's mouth. There's an old wives' tale many years ago that patients can swallow their tongues during a seizure. Well, you can't swallow something that's attached. They may bite their tongue, but they're not going to really swallow the tongue. Back many years ago, and Andrew may have been with me, we responded to a call of an elderly gentleman, never had a seizure before. And to this day, I don't know what caused the seizure, but the son was there with the patient, the adult son. He said, Dad's going to swallow his tongue. So the son goes to the kitchen and grabs a spoon, a large plastic serving spoon, and crams it into his father's mouth. Well, patient didn't swallow his tongue, but he wasn't going to. However, the patient did end up with several broken teeth as a result of having that plastic spoon shoved down his mouth, or shoved down his throat. I believe that this probably happened out on Mullins Ridge many years ago, Andrew.
Seems like I may not have been with you, but it seems like I heard about it.
You probably heard about it anyway.
Yeah.
That absolutely removed any doubt in my mind when it came to the use of these things that they called seizure sticks, which were nothing more than plastic tongue depressors, basically. They were really thick. Another type of seizure we may want to mention, pediatric seizures. Some children have a lot of seizures. Some children have epilepsy. They have other health conditions going on. Generally, in those situations, the parents know a lot about the health status of the child, and they may be calmer in that situation than you are. Remember to keep yourself under control. Also, with pediatric seizures, you may end up seeing what's called a febrile seizure, which is fever or temperature-induced seizures. Those do happen from time to time. We're just going to keep the child cool. If the patient appears to be really hot, and we're going to maintain airway, breathing, and circulation, transport the patient to the hospital. Do whatever other procedures are necessary based on what happens next. The term status epilepticus is a term which means prolonged or nonstop seizures. The patient seizes, they never fully wake up, and they seize again. If you have that condition, the patient probably has a major underlying condition going on. Okay, other altered mental status issues out there. Strokes. So, talked just briefly before, a stroke is caused by either a blood clot within the circulation of the brain or a bleed that occurred within the brain. Now, with a stroke, some people call these brain attacks. I believe the American Heart Association is trying to call it a brain attack. The medical term has generally been cerebrovascular accident, or CVA. Imagine back when we talked about heart attacks and we talked about coronary artery blockages. The blood clot moves around, blocks the coronary artery. Blood doesn't move past the point of the obstruction. So if blood is not moving, that means oxygen is not moving. Heart muscle dies. Well, this same thing happens with strokes. Okay. With a stroke, the clot gets lodged in a blood vessel within the brain. Blood stops being delivered to the brain, and of course, blood transports oxygen, so the brain begins to become damaged and can eventually die from lack of oxygen. Seizure patients, or not seizure patients, but stroke patients often have one-sided effects, such as one side of the face will droop, one arm will droop. If you ask a patient to hold both hands out in front of you, the affected side will start to drift away. Okay, patient may be totally paralyzed on one side. The pupils may be unequal. Those are those one-sided symptoms. The legs, one leg may be able to raise up better than the other. They may be able to wiggle the toes on one foot versus the other foot. Other things that can happen with a stroke, you have some speech impediments. The speech becomes slurred, or maybe the patient even starts using the wrong words. You know, the speech becomes slurred because of a neuromuscular issue. You're not able to use those muscles to form words and talk correctly. But if you've actually got a brain problem going on, you may start choosing the wrong words, or not know which words to use, or completely stop speaking at all. Okay. There is a condition called, go ahead.
I was just going to say, we had an ER doc, I can't remember which one it was, but He said something to me that kind of stuck with me, is that any major sudden changes in especially an older patient's behavior or mental status, without anything else to explain it, should be considered a possible stroke and a high likelihood of stroke. So, give you an example. A couple of years ago, my grandmother had a stroke, but she didn't have the one-sided weakness or anything like that. She became really altered in her mental status, and come to find out she was having a stroke. So just something to keep in mind also.
Yeah, I like it. We're just going to suspect a stroke unless we've got some other strong suspect to explain what's going on with the mental
Yeah,
status or the.
especially an older patient that has all the risk factors for stroke. Unless you have something else to explain what's going on, probably should consider possibility of a stroke.
I think it makes total sense. It really does. Now, with heart attacks and chest pain, we talked about a condition called angina. And angina is when blood flow is reduced or temporarily stopped to the heart muscle. Well, we can have something very similar occur in the head, in the brain, when blood flow or oxygen has slowed down. Your patient may have what's called a transient ischemic attack, TIA. What does grandma call a TIA? What do
Mini
they
stroke.
call it? Huh?
Mini stroke.
A mini stroke. That's right. A mini stroke. Okay, a TIA is a mini stroke. You get those same stroke symptoms, but your stroke symptoms seem to fade and go away. Okay, just like angina will go away. How do we know what's a mini stroke and what's a real stroke? We really don't. We're going to treat our patient just the same. Okay. I'm going to go ahead and show a video about stroke assessment. Once I can find it here. Oh, come on. Okay, I'm going to share my screen.
To edit documents anytime, anywhere, from any device. Add text anywhere.
Hi, I'm Wade. I'm a paramedic, and I'm also a EMT instructor with Idaho Medical Academy. Today in this video, we will be going over strokes and what a stroke assessment would look like on a call.
Medical 7, please be en route to 2323 South Vista for a 50-year-old male complaining of weakness.
Hi, sir. What's your name?
My name is Hubert.
Hubert. My name is Wade. Nice to meet you. What's going on today, Hubert?
Well, I was working on my computer and all of a sudden I started feeling some numbness and tingling in my left hand, and all of a sudden it just stopped working.
Okay, your left hand started working. Let me ask you some silly questions.
Yeah.
Do you know what city we're in right now?
Yeah, Boise.
Do you know what year it is?
2022.
2022. Not quite. Do you know who the president is?
Biden.
Okay. And then do you know why I'm here today?
Yeah, my coworkers were concerned and called 911.
Okay. So when I arrived on scene, my general impression of the patient is that I see a gentleman kind of slouching over to one side, appears to be a little bit altered as far as his mentation goes. So I was able to quickly ascertain that he was alert when we're going through the AVPU scale, based on him being able to track me as I'm walking in with his eyes, as well as him communicating as I approach him. I then asked him his orientation questions, his person, his place, time, and event, to kind of see where he is and if he's either ANO ×4, alert and oriented ×4, or he is altered. All right, I'm going to listen to your lung sounds, okay, Hubert?
Okay.
Go ahead and take a deep breath for me. Take another one. Okay, I'm gonna get under your armpit. So now we've started moving into the ABCs, our airway, breathing, and circulation. I can tell immediately that his airway is clear and patent because he's talking to me. I don't seem to be concerned about any obstruction to the airway. I checked his circulation almost immediately, right? I grabbed his hand when I was shaking it, introducing myself, putting my fingers on his wrist, feeling that radial pulse. I then decided to listen to his lung sounds. Once again, we are looking for the quality of the respirations. Is it wheezing, clear, stridor, or rhonchi? I noticed that he had equal and bilateral chest movement. And I also did notice that he did not have any difficulty breathing. He wasn't seeming to struggle to breathe. With his circulation, however, I did notice he did have an irregular pulse. It wasn't beating in a regular cadence. It was an abnormal cadence. So Hubert, I'm gonna have my partner here get some vital signs on you, okay? I'm also gonna include what's called a blood glucose, okay? We're gonna poke your finger. Based on my findings so far, I'm a little bit concerned about you, and I think it'd be a good idea for us to run you into the hospital, okay? Pretty concerned with my findings.
Okay, thank you.
Okay. Based on my findings and with my vital signs, I decided that this patient is what we would consider a emergent transport. We're going to get him transported to the hospital so that he can receive a more definitive level of care. Okay, Hubert, I'm going to ask you some questions about yourself. Do you have any allergies to any medications?
Yes, I'm allergic to penicillin.
You're allergic to penicillin. Okay.
Yeah.
Do you take any medications regularly?
Yes, I take Coumadin and I take lisinopril.
Okay. Do you have any medical history at all?
Yes, I have. Oh, my doctor told me I have an irregular heart rhythm. That's what I take Coumadin for, and I take lisinopril for my blood pressure.
Okay. Okay. When's the last time you ate or drank anything?
I had some coffee this morning, and I had a Hot Pocket breakfast burrito. Don't tell my wife.
I won't.
Okay, she'll be upset.
And then what were you doing before we called, just as a recap here?
I was working on my computer, and then it just started happening. The weakness.
That weakness, and it just came out of nowhere on you?
Yeah.
Okay. Okay. So we just got our sample history, our signs, symptoms, allergies, medications, pertinent medical history, last oral intake, and events leading up to the scenario. The patient did say he has an allergy to penicillin. Now, that being said, it is not super pertinent to the call type today, though it should be considered moving forward in case we are going to be giving them to the hospital and they might need antibiotics. The big findings with our sample history actually come from his medications and his pertinent history. In his medications, he listed that he takes lisinopril, which is used to help control blood pressure. He also takes Coumadin, which is known as a blood thinner. Makes it easier for blood to pass through the body. When I asked him about his personal history or his pertinent history, he did say that he has a history of an abnormal heart rhythm. Abnormal heart rhythms, such as atrial fibrillation, will have an irregular beat, so it will not be at the regular cadence. It also will put you as a higher risk for clotting factors because of that blood pooling in the heart. So he takes the Coumadin related to his atrial fibrillation. That is a key context clue to help guide us to our answer about what's going on today. Okay. So Hubert, I'm trying to get a little bit deeper understanding of what's going on today, okay? I'm going to ask you some sillier questions as well. Have you drank any alcohol today?
No.
Okay. Are you a diabetic at all?
No, I'm not diabetic.
Not diabetic. Have you ever had seizures or been diagnosed with epilepsy?
No.
Okay. What about have you taken your medications appropriately?
Yeah, I take it every morning.
Every morning, you're not
Yeah.
taking more than you should.
No.
You're not taking any extracurricular illicit substance.
No.
Okay. What about if you're urinating? Does that burn at all? Do you have any discomfort urinating?
No.
Okay. What about falls? Have you fell at all? Hit your head lately?
No. No falls.
Okay. What about feeling sick? Have you had any fevers, chills, coughs?
No. No.
Okay. And then any mental health conditions I need to be aware of?
No. Just life stress.
Okay. And then have you ever had anything called a stroke before?
No. No. I never had a stroke before.
Okay. Well, Hubert, I think you might be having a stroke right now. I think that's what that weakness is on the left side of your body. That's why you feel a little funny. So what I'm going to do is I'm going to do a test we call the FAST test. So it's a couple of silly things. So I'm going to have you look right here at my nose. Give me a big smile. Show me all your teeth. Perfect. All right. I'm going to take your arms here, Hubert. I'm going to hold them here. Close your eyes for me. I'm going to drop your hands. Try and keep your hands right where they are. Okay. Okay. Sounds good. Go ahead and relax that hand, Hubert. Open your eyes. I'm going to ask you to repeat a phrase for me. Can you do that?
Yes.
Can you repeat, you can't teach a dog new tricks?
You can't teach a new dog new tricks.
Okay. And then when did this start? Do you know the time that this started by chance?
Probably 30 minutes ago.
Probably 30 minutes ago.
Yeah.
Okay, sounds good. Yeah, Hubert, based on my findings, I would say you're having what we're calling a stroke. Okay, something's going on with your brain and it's causing the left side of your body to not function normally.
Okay.
So I think we need to get you moving. So we'll get our gurney ready and we'll get you moved over before we get you in the ambulance, okay?
Thank you.
Okay. As you can see in the video, I was asking questions pertaining to the AEIOU TIPS acronym. The S in TIPS is stroke, which led me to start a Cincinnati pre-hospital stroke assessment, otherwise known as FAST. So if we're looking at the patient, I noticed I had him smiling. I noticed the left-sided facial droop. I had him raise his arms, palm side up. I noticed left-sided arm drift. The patient was also slurring his words, and he was also a little bit of what we call aphasic. He was unable to completely answer my questions, and his words kind of seemed a little bit off. And the most important factor of this is he was able to tell me the time. When did this start? In strokes, time is one of the most critical aspects to making sure the patient has a higher successful survivability rate.
What's your credit card debt balance? If it's $10,000 or more, here are 3 easy solutions you can start implementing today.
Just to clarify, I've got some questions for you, okay, Hubert? Have you been on any long trips lately? Been sitting in a car or on an airplane?
No.
No. Have you ever had any recent surgeries at all?
No recent surgeries.
No recent surgeries, but you do have that abnormal heart rhythm, right?
Yeah.
And you do take Coumadin for that,
Yeah.
blood thinner. Okay. So following my FAST assessment or my Cincinnati pre-hospital stroke assessment, I was able to determine that the patient is displaying signs of a stroke. Now, my treatment plan, being an EMT basic, is a little bit limited. All I can really do is to support the ABCs. If the oxygen level starts getting low, I can provide some supplemental oxygen. Okay. Another part of our treatment plan is going to be how fast are we transporting this patient? They would be considered a rapid transport or a critical patient. And while en route to the hospital, we would be reevaluating this patient's vital signs every 5 minutes or so due to their critical status.
General Hospital, Medic 17.
Go ahead, Medic 17.
Medic 17 currently en route to your facility, code 3 emergent, with an alert and oriented 50, that's 50-year-old male. Chief complaint today is going to be a code CVA, code brain attack. The patient is displaying signs of left-sided facial droop, left arm drift, slurred speech. It began about half an hour ago, last known well half an hour ago. Last blood sugar we got on him was going to be 86. Last set of vitals we have for this patient. Pulse rate is 100. Last blood pressure 185 over 100, setting 95% on room air. We have a current ETA to your facility of about 6 minutes. Any questions?
So that was an example of a real radio report that I would give for a patient having a stroke. That's all we really have for you guys today. Like and subscribe this video. Don't forget to check out our website, idahomedicalacademy.com.
Okay, just a little insight on stroke assessment. Folks in our part of the world here in Southwest Virginia, we're a pretty decent distance from a stroke center. If you're in an isolated area and you got a long transport time to a facility, you may want to consider calling a helicopter for air medical transportation. But you should never, ever call for a helicopter and sit and wait while your patient continues to go downhill. You know, the saying time is muscle is often used when dealing with cardiac emergencies. Well, time is also brain and brain function. So delayed transport can really result in a worsening of the symptoms, just a worsening of the condition, and a poor outcome in the end. This patient needs to be transported to a facility where they can be treated. Most facilities are able to do a CT scan now, rule out the possibility of bleeding within the brain, and administer some of these clot buster type medications to help control or even stop and reverse a stroke. So you need to make sure that that patient gets to a facility quickly. Which facility? Again, that really goes back to your agency protocol. My personal feeling is you need to get them to the closest appropriate facility. And if you have an extended transport time, you may want to consider calling a helicopter if it's available and you think you can actually get them in the air and to the receiving facility quickly. Sometimes helicopters have seemed to delay patient transport if you're not careful. Okay. Other portions of this chapter, dizziness and syncope. We know what dizziness is. Syncope means to faint or to pass out. There's different causes of dizziness and syncope, such as cardiovascular problems. Maybe the heart's not pumping efficiently. You're not getting enough blood and therefore not enough oxygen circulating to the brain. You may have a hypovolemic cause. Maybe the patient is too dehydrated or they have bled out a lot. Maybe you've got a metabolic issue. The body's chemistry is simply out of order. Okay? Sometimes you have environmental and toxicological causes of syncope and dizziness. They've been exposed to carbon monoxide gas, for instance, some other type of poisonous substance or drugs. Remember our onset, provocation, quality, radiation, severity, and time, OPQRST, when you assess your patients. OPQRST basically rolls into the S in sample and helps you determine what's going on. If you have a patient with altered mental status, and that altered mental status is new, go ahead and assume that this patient is having an emergency. Be sure to get a good set of vital signs. Be sure to check a glucose level if you have a glucometer available on your ambulance. Consider possible outside sources, such as environmental toxins. Be alert for the possibility of alcohol and drug-related issues. Be aware of sepsis, which is a systemic infection, which can result in multiple problems within the body. We've got a chapter on that we're going to go over soon. Make sure you're safe. Do your initial scene survey. Make sure the patient's airway, breathing, and circulation are in check. Fix any problems that you find, and then continue right on down the line with your patient assessment. Transport your patient to the closest appropriate facility based on their condition. Okay, that should finish this chapter up. Do you have anything to add there, Andrew?
No, I can't think of anything else.
All right, that's great. I will see everybody Thursday at the breaks at noon. Wish Andrew could join us, but we will persevere. We will, at that point, we will practice using the glucometer. We will simulate administering oral glucose. Then we'll talk about allergic reactions and medication that we can administer for allergic reactions, called epinephrine. We will key in on some infectious diseases, and we will be talking about poisoning and overdose emergencies. We're going to have a very big day Thursday. You're going to be extremely busy. I hope to see everyone there. If you have any questions, don't hesitate to send me an email and ask. I will be posting this video up to YouTube so everyone can watch it this evening. Andrew, I appreciate you joining us.
No, thank you.
And I'll catch up with you later on what we've been talking about.
All right, sounds good.
All right, folks. I'll see everybody Thursday. Thank you.